Good morning. My name is Nancy McAuliffe, and I am a representative of the Maryland Department of Health and Mental Hygiene. I'd like to welcome you to the 6th Breastfeeding Educational Webinar for Healthcare Providers. Today you'll hear the presentation Beyond the Sacred Hour, Supporting Exclusive Breastfeeding in the Early Postpartum Period. This program is part of the Maryland Department of Health and Mental Hygiene Hospital Breastfeeding Policies Physician Webinar Series. After completing this presentation and successfully completing a post-test, physicians will receive 1 hour of continuing medical education. This CME will be available through June 2019. DHMH thanks LifeBridge Health and Dr. Dana Silver for partnering with us to make this possible. Per DHMH policy, we remind our listening audience of the recommended steps to reduce contracting the Zika virus, which can cause serious birth defects. Citizens are advised to avoid mosquito bites, use insect repellent, and empty containers of standing water. This slide pictures the species of mosquito that spreads the Zika virus, and here are websites that you can access to find more information. I now want to move on to our presentation. Your speaker today, Dr. Raylene Phillips, received a master's degree in developmental psychology after raising 3 children as a stay-at-home mother. She became NID CAP certified as an infant developmental specialist and then attended medical school at University of California, Davis, graduating in 2004. She completed her pediatric residency and neonatology fellowship at Loma Linda University Children's Hospital in Loma Linda, California, and is currently an attending neonatologist in the NICU at the same hospital, as well as medical director of newborn nursery at Loma Linda University Medical Center, Murrieta. Dr. Phillips is an international board-certified lactation consultant and is a fellow of the Academy of Breastfeeding Medicine. She is the current president of the National Perinatal Association. Her primary areas of interest are mother-infant attachment, breastfeeding education and support, and family-integrated neuroprotective care of premature infants in the NICU. And now I'll turn it over to Dr. Phillips.
Thank you so much. I'm very happy to be with you today to talk about this aspect of breastfeeding that we sometimes find quite challenging, supporting exclusive breastfeeding in the early postpartum period. I have no conflicts of interest and no disclosures to make, except that I have a great passion for the well-being of babies and their families, which I'm sure is shared by all of you that are listening today. All baby mammals are born knowing how to breastfeed, and this is true for all species. They all have instinctive feeding behaviors at the time of birth that are activated when they are skin to skin with their mothers, and human babies are no exceptions. Because the first hour after birth is a very special time where babies seem to be uniquely primed to breastfeed for the first time, at our hospital we call this hour or two the sacred hour, meaning a time that is set apart as highly important, valued, and respected. What has become very clear, however, is that even if a baby gets to spend that first hour or two after birth in skin-to-skin contact with mother, there are often challenges yet to overcome to ensure successful breastfeeding. While the sacred hour may be necessary for the most optimal start in breastfeeding, it is often not sufficient, at least at this time in our culture. There are just so many barriers to breastfeeding for human babies, in our particular culture at least, that we have to make a conscious effort to be aware of those barriers and to create often individualized solutions to overcome them. This is a chart of United States breastfeeding rates in 2010 and the 2020 Healthy People Goals for Breastfeeding. You can see we have come a long way from 1971 when the initiation rate for breastfeeding was only 21%. As you can see, initiation of breastfeeding is no longer our biggest problem. Our biggest challenges now are duration of any breastfeeding and exclusive breastfeeding for the first 6 months after birth. There's no longer any debate about the benefits of breastfeeding compared to formula feeding. The risks of not breastfeeding are so well documented that the medical profession no longer considers breastfeeding to be just simply a lifestyle choice. Breastfeeding is now considered to be a public health issue. As we remember, smoking had a similar history where it was once considered to be a lifestyle choice, but it is now well understood to be a public health issue. The many benefits of breastfeeding babies are so well known that most mothers want to breastfeed. What I've found, however, is that they often are not at all confident that they can succeed. When I ask moms, are you planning to breastfeed your baby, they say, well, yes, I would like to try. And when I ask, how long are you planning to breastfeed your baby, they often say, well, just as long as I can. I recently heard about a study that asked mothers if they had breastfed their babies as long as they wanted to, and over 50% had not. Since most mothers these days want to give breastfeeding a try, it's up to us to help them succeed. Someone has recently said, if we want mothers to exclusively breastfeed for the first 6 months, first we need to help them exclusively breastfeed for the first 6 days. Now, I'm not going to be giving you an exhaustive overview of the benefits of exclusive breastfeeding, but I'd like to share with you just a few tidbits of information that I have found particularly compelling in support of exclusive breastfeeding, a goal that everyone agrees is optimal, but often elusive and difficult to achieve. We will discuss immune protection, optimal growth and development, and the cost to families and societies. And then we will go on to discussing some common challenges and some evidence-based practices that support exclusive breastfeeding in this time period, such as hypoglycemia, hyperbilirubinemia, early weight loss, maternal concerns, and breastfeeding myths. So we'll start with immune protection. It's common knowledge that breastfed babies have some protection from certain illnesses, but most people do not have any idea just how much babies are dependent on mother's milk for immune protection. Human milk is not just a fluid, it's a living tissue. This magnified image clearly shows the differences between the inert, lifeless fluid of artificial milk and the complex living tissue of human milk. Human milk has been described as more similar to the complexity of blood when considering the variety of cells and compounds found in both. The list of host defenses in human milk is impressive. The enteral mammary immune system is antibodies and activated lymphocytes to pathogens in their environment that both she and her newborn are exposed to, and then passing this immunity through her milk to her infant. Pretty amazing. And another reason for skin-to-skin contact, so that the baby can colonize mother with the pathogens that they are both exposed to. Yet even many medical professionals are unaware of this mechanism of immune protection for newborn infants. Good health, some have said, begins in the gut. The gut is actually the largest immune organ in the body. Yet it is quite immature at birth, with significant intestinal permeability. This is because the tight junctions of the GI mucosa are not very tight at the time of birth, and they take several weeks to mature and close. And until they close, pathogens and whole proteins can get through in between the cells of the GI mucosa and be absorbed directly into the bloodstream. The growth factors in breast milk help the gut to mature faster and close these tight junctions sooner than babies who are fed formula without these growth factors. And breast milk also has a backup plan in the form of secretory IgA, which coats the gut like a wallpaper over a screen to provide passive immunity during this time of vulnerability. Another mechanism of protection includes oligosaccharides found in plentiful supply in human milk. Much exciting research is currently being done on oligosaccharides, which may be one of the most important components to protect very preterm infants from necrotizing enterocolitis. Some formula companies have added 2 or 3 kinds of oligosaccharides to artificial milk, but there are over 200 different types of oligosaccharides in human milk. Oligosaccharides are not only prebiotics supporting beneficial bacteria in the gut, but also act as decoys for pathogens. Here's a cartoon showing a norovirus inside the gut of an artificially fed baby. Here are the norovirus receptors attached to the intestinal mucosa, and here they are attaching to the norovirus. So now it can be absorbed through the intestinal mucosa into the bloodstream and causing this baby diarrhea that may indeed be life-threatening. Whereas the breastfed baby has oligosaccharides floating around. supplied by human milk, and these bind to the norovirus, making it impossible for them to get through the mucosa into the bloodstream. Human milk promotes normal gut flora in which lactobacillus is a probiotic predominates, and gram-negative organisms are almost completely absent. It also creates and maintains a low intestinal flora. You can see with each addition of formula how the pH increases, making it less acidotic and less protective. Formula-fed babies are at higher risk for inflammatory response when pathogenic bacteria slip through those loose, tight junctions into the bloodstream, causing inflammation. When this happens, there is increased interleukin-8 and other pro-inflammatory cytokines that could lead to a systemic inflammatory response, which can be responsible for local organ damage in the preterm gut or distal organ damage, such as chronic lung disease and neurodevelopmental delays. So there are well-documented risks to feeding artificial milk to babies. Even one bottle of formula changes the bacterial profile of breastfeeding infants so that they resemble more that of formula-fed infants. And it can take 2 to 4 weeks of breastfeeding for the gut to return to the normal flora, which is more protective. The pH becomes higher, the tight junctions widen, the baby is exposed to a higher risk of an inflammatory response from colonization with pathogenic bacteria. And while these are very real risks, and exclusive breastfeeding is obviously ideal, formula does not need to be demonized because it has played an important role in keeping babies alive when mother's milk was not available. Having a formula that most babies can tolerate is absolutely necessary in specific situations. I find it useful to compare it to antibiotics, which can be absolutely life-saving in specific situations as well. But antibiotics are known to have risks, which can range from a mild rash to hives to anaphylactic shock. Diarrhea and yeast infections are well known, and many other harmful effects. So antibiotics should be used only when needed and for the shortest therapeutic period necessary in order to use them responsibly. And we can make the same analogy for artificial milk feeding. Artificial milk should be used only when there is no other option and for as short a period of time as therapeutically necessary. The degree to which human milk protects from sepsis in hospitalized infants is profound. In this study, as in many others, babies fed formula had twice the rate of sepsis in the first 10 days, and the difference in sepsis rates between breast milk and formula-fed infants increased over time. For me, these are very compelling reasons to encourage and support exclusive breastfeeding. There's much more we could discuss about immune protection, but there are other reasons. Every species of mammal has different metabolic and growth patterns, and the milk that each species makes to feed their offspring is specifically designed to optimize the growth and development of that species. Human milk was designed specifically for human infants, and cow's milk was designed specifically for cows. And yet the dairy industry has done a masterful marketing job in convincing us that humans absolutely need cow's milk for optimal growth. Humans are the only species that continues to drink milk past infancy, and the only species that feeds their infants milk from another species. The fact that milk from each species is different is news to most parents and to many professionals as well. Baby whales need a high concentration of fat for protection from cold. Baby cows need high calcium and phosphorus for rapid bone growth. And human milk has the highest percentage of carbohydrate to meet the needs of rapid brain growth, as humans have the highest brain-to-body ratio of all mammal species. Now, it's not just the percentage of milk components that are unique to each species. The nutrients themselves are quite different. Cow's milk protein, for example, is very different from human milk protein. The casein-whey ratio is very different, and even the casein itself is a different type, forming different sized micelles that lead to curds with different consistencies. Cow's milk proteins are just not designed to be digested by human babies' digestive enzymes. So it is always harder for human babies to digest formula made from cow's milk, and some babies have a very difficult time tolerating cow's milk protein at all. Lactose is the principal carbohydrate in human milk and comes with its own digestive enzyme, lactase. Newborn infants are never lactose intolerant except in very rare genetic disorders. Oligosaccharides are another important form of carbohydrates, and we've already mentioned some of their multiple functions. Fats provide 50% of calories in human milk, and breast milk is particularly high in cholesterol, which is needed to enhance intestinal membrane stability and is essential to myelin formation in the rapidly forming brain. Long-chain fatty acids are also essential for brain and visual development. And two we have heard a great deal about are arachidonic acid and omega-6 and docosahexaenoic acid and omega-3. These factors in human milk may help to explain why studies have consistently shown breastfed children to score higher on tests of IQ and mental development. I love this particular study because it documents that females are born with a 4-point IQ advantage, at least in its study population. However, preterm boys get an 8-point IQ boost if they are fed with breast milk. And this is an important point to bring up to parents of newborn baby boys. This chart is a meta-analysis that examines the results of a dozen breastfeeding studies. Anything to the right of the red line indicates a positive result of the intervention, and anything to the left means a negative result. And this study showed all 12 studies reviewed showed positive results for IQ if babies were fed human milk. This is a more recent systematic review in the meta-analysis published in 2007 by the World Health Organization, showing the same results with 8 different studies that are newer. The longer a baby breastfeeds, the higher the IQ, even after adjusting for multiple factors. Since fat is so important for brain and vision development and intestinal membrane integrity and temperature stability, as well as an important energy source, it is vital that it be readily available to the newborn infant. And as it turns out, fat from human milk is more easily absorbed than is fat from artificial milk. And there are several reasons why this is true. First of all, just like human milk carbohydrates, it comes with its own digestive enzyme. Human milk fat digestive enzyme is lipase, and human lipase is designed specifically to digest the fat in human milk, not the fat from the milk of other species. Let me give you some examples. 98% of fats are in the form of triglycerides, in milk that is, which are made up of saturated and unsaturated fatty acids attached to a glycerol backbone in specific positions. There's 3 of them because it's a triglyceride. Now, 75% of saturated fatty acids are palmitic acid, and in human milk they are attached in the middle position, and in bovine milk they are attached on the 1st and 3rd positions. I thought this was so fascinating, I made this slide to show you how it makes a difference. So here's a human milk triglyceride with the saturated fatty acid in the middle, and here's an artificial milk with the saturated fatty acid on the sides. Lipase, the digestive enzyme, comes along and it separates the 1st and 3rd fatty acids. That's its job. And in the case of human milk, these are unsaturated fatty acids, which are very easily absorbed for all of the nutritional reasons that babies need fatty acids. Whereas in artificial milk, when the 1st and 3rd are released, they are now saturated fatty acids, which are not so easily absorbed. In fact, they tend to form hydrated fatty acid soaps with minerals such as calcium and magnesium. And we know that insoluble calcium soap formation may lead to constipation. And when I saw this, this was the first time I understood the mechanism by which some babies are constipated when they switch from mother's milk to formula. And it very aptly illustrates the very fundamental difference between these 2 nutrition sources. Now, many families struggle with finances, and here's one way that they can save significant amounts of money on their grocery bills, while at the same time saving on their medical bills. It has been estimated that the average baby drinks a little over 9,000 ounces of milk in the first year, and this can cost between $1,200 and $1,900, not an insignificant amount for most families. The cost to society is not pennies either. If 90% of U.S. families could comply with the medical advice to breastfeed exclusively for 6 months, the United States would save over $13 billion a year and prevent over 900 deaths. If even 80% could comply, we'd still save a significant amount of money and prevent a significant number of deaths. In the early postpartum period, there are several common challenges to exclusive breastfeeding that we run into over and over again. There's a great deal of variety among practitioners in the way these common challenges are managed, and therefore there's much confusion. So I want to look at a few of them and see what evidence is out there to guide our management in ways that support exclusive breastfeeding while at the same time safeguarding babies who are at risk. We'll start with hypoglycemia, which this baby is likely to have been at risk for shortly after birth, because we've all seen those cheeks. There's actually a variety of risk factors for babies who are born at risk for hypoglycemia. We can't ignore them. They're very real. To start with, the very definition of hypoglycemia is controversial. It's understood that there are no significant correlations between plasma glucose levels and symptoms and long-term sequelae. There's a difference in the type of sample study, which adds to the confusion. And we know that bedside glucose testing strips are good for screening, but they vary significantly from true glucose levels. Today we're going to review the evidence-based practices recommended by the American Academy of Pediatrics. Wait, let's go back here. And the Academy of Breastfeeding Medicine. But first of all, I want to review one of the biggest sources of confusion, and that is the physiologic nadir that occurs in the first hour after birth. First 2 hours after birth. It's actually the first 2 to 4 hours after birth. This is a normal drop in glucose that is self-limiting. It spontaneously arises in 2 to 3 hours whether the baby is fed or not. And in normal babies, this is compensated for by a ketogenic response to protect the brain. Even with prolonged intervals between feeds, most babies' brains are well protected. There's no evidence that asymptomatic hypoglycemic infants benefit from treatment because they all have normal neurological outcomes because of this ketogenic response. So these are the two evidence-based practices that we're going to look at, Academy of Breastfeeding Medicine and the AAP. They're actually quite similar, so I'm only going to review them briefly. We'll start with the AAP 2011 guidelines. These guidelines begin by acknowledging that breastfed term infants have lower concentrations of plasma glucose than do formula-fed infants, and they're just fine because they also have higher increased ketogenic responses. They acknowledge that there's no single concentration of glucose concentrations that are associated with clinical science, and that any glucose concentration that is said to define hypoglycemia is without rigorous scientific justification. We also know that with symptomatic infants with low glucose, there's no controversy. We know what to do. We treat them with IV glucose. Where the confusion lies is in the at-risk asymptomatic infants, and one of the reasons for the confusion is that their management differs from the period of birth to 4 hours, then from the period of 4 hours to 24 hours. So this is a very busy chart that summarizes the screening and management of postnatal glucose homeostasis in 4 groups of at-risk babies, 2 groups of small babies and 2 groups of big babies. The 2 groups of small babies include the late preterm infants from 34 to 36 and 6-7 weeks, and also the full-term small for gestational age babies. These babies should be screened for 24 hours after birth. And then the 2 groups of large babies are the infants of diabetic mothers and the large for gestational age babies. And those babies should be screened for at least 12 hours. Now again, we know what to do with symptomatic babies, but the asymptomatic babies, when they are birth to 4 hours, the recommendation is to feed them initially within 1 hour and then screen 30 minutes after the first feed. And then they give some parameters and guidance as to what to do. Whereas in 4 to 24 hours, we continue to feed for every 2 to 3 hours, and I would say 1 to 3 hours. And then the numbers are a little bit higher, the thresholds. So let's look at this a little bit more closely. This is where it gets interesting. From birth to 4 hours, feeding should begin with 1 hour, glucose testing 30 minutes after the first feed and not before the first feed. If the glucose level is less than 25 milligrams per deciliter, we are to refeed and recheck glucose in an hour, as long as the baby is asymptomatic. And if the second glucose level is between 25 and 40, we can refeed again, or we can start IV glucose. And if it remains less than 25, then of course we start IV glucose. Now in the hospital where I work, the AccuChecks are said not to be accurate at less than 40, so we have shifted that threshold level to 40 instead of 25. However, knowing that the experts say less than 25 is fine as long as the baby is asymptomatic, gives us a little cushion and a little window where we know that as long as the baby is asymptomatic, we have time, if we want to be able to get a little bit of colostrum if we do it quickly, or feed just a small amount of formula. Now from 4 to 24 hours, the only thing that differs really is that we continue to feed the baby, and now the glucose level needs to be less than 35 instead of 25. And we refeed and recheck glucose in an hour. And once again, it has to be 40 in my hospital, but this is what the experts say. What is interesting is that while the target glucose level is greater than or equal to 45, it's acceptable to have the glucose goal between 40 and 50 milligrams per deciliter. And the authors of these guidelines specify in the text that trying to get the glucose levels higher than 50 is really self-defeating, because it just drives the insulin levels higher in infants of diabetic mothers, and then that will drop the subsequent glucose level lower. So 40 to 50 is considered to be a safe and adequate level for glucose in the asymptomatic baby. Now the ABP guideline, Academy of Breastfeeding Medicine protocols can be downloaded for free at www.bfmed.org, and this was one of their very first ones that was revised in 2014. And again, the research base is pretty much the same, and so they have very similar recommendations. And here we see that they document the lower thresholds early after birth, and confirm that early and exclusive breastfeeding does meet the nutritional and metabolic needs of healthy term newborn infants. They caution against routine supplementation and how it can interfere with establishing normal breastfeeding and normal metabolic compensatory mechanisms. We want to initiate breastfeeding within 30 to 60 minutes after birth, and then feed on demand whenever the baby has a feeding sign or cue. Feeding should be frequent, a minimum of 10 to 12 per day in the first few days after birth, and we need to facilitate skin-to-skin contact of mother and infant. For the asymptomatic hypoglycemic infant, we need to breastfeed every 1 to 2 hours, and if necessary, express some colostrum or donor milk if supplementation is desired, and not more than 3 to 5 milliliters per kilogram if the baby is not breastfeeding. We need to recheck the blood glucose levels before feedings until the value is normal, and if it remains low, obviously begin IV glucose, but continue to support breastfeeding even during IV glucose therapy. It's important also to support mothers. Concerns or risks for hypoglycemia can cause stress to mothers and families, especially with all the heel sticks. We need to assure mother that there's nothing wrong with her milk, and assure her that any needed supplementation is usually temporary. We want to have mom hand express or pump milk if we're supplementing her baby with formula. This can help her overcome feelings of inadequacy and also help to establish a full milk supply. And it's important to continue this until the infant is feeding well. And through all this, we want to facilitate skin-to-skin contact for all the reasons that we know skin-to-skin contact is important. Let's take a look at another common challenge in the first few days after birth, hyperbilirubinemia. Once again, there are many important risk factors to consider for both infants and maternal risk factors that make this an issue we simply cannot ignore. There's a common confusion that revolves around which type of jaundice the baby has, and the biggest confusion stems from the term breastfeeding jaundice, when people really mean starvation jaundice, which is not due to breastfeeding, but rather from a lack of adequate breastfeeding. So I would encourage you to use the term starvation jaundice rather than breastfeeding jaundice. Now, I probably don't need to explain what physiologic jaundice is to you, but I think it's useful to point out to parents that bilirubin has a functional role. It's a potent antioxidant, and a significant number of babies have bilirubin levels that are elevated in the first week after birth. Starvation jaundice, however, is different. It most often occurs when there is inadequate breastfeeding support, but occasionally it can occur even with the best support due to breast hypoplasia or other anatomical or hormonal issues with either mother or even anatomical issues with the baby, such as ankylosing or tongue tie. Anything that hinders a good latch or good milk transfer can contribute to inadequate intake and starvation jaundice. And it's not unique to infants. This is a physiological process that occurs in adults as well if they don't get enough to eat. It may occur even without absolute starvation, just lower than adequate intake. So relative starvation leads to an increase in intestinal absorption of bilirubin and a decrease in the passage, and in the newborn's case of meconium. So breast milk jaundice is the third type that we typically deal with in the newborn period, and this is unconjugated hyperbilirubinemia that extends into the second and third weeks after birth, and often up to 8 to 12 weeks in about 2/3 of breastfed infants. But these infants are not starving. They're vigorous and feeding well and gaining weight. And they do have enhanced intestinal absorption of bilirubin, which may come from genetic or familial factors. Intervention is usually not necessary according to the protocols unless the levels exceed 20 milligrams per deciliter. And either phototherapy or formula feeding for about 12 hours will both bring those levels down. In the first week, it is either exaggerated physiologic jaundice or starvation jaundice that is usually our concern. So let's see what the experts have to say. We'll start with the Academy of Breastfeeding Medicine, which is protocol number 22. And they generally recommend early initiation of breastfeeding, obviously, preferably in the first hour after birth. And they didn't put this in their guidelines, but I would say both vaginal and cesarean deliveries. Exclusive breastfeeding is encouraged, and feeding anything prior to the onset of breastfeeding we know delays the establishment of good breastfeeding and the establishment of adequate milk supply. So this increases the risk of starvation and weight loss and exaggerated hyperbilirubinemia. They encourage us to optimize breastfeeding management from the very beginning, which means we need adequate lactation consultant support and good education for our bedside nurses. We want to ensure a good position and latch from the beginning, and to identify babies that are having difficulty. It's important to provide education on early feeding cues so that mothers can put babies to the breast before they start to cry. In this study of 140 Japanese babies, all babies roomed in with their mothers, and mothers recorded the number of times they breastfed in the first 24 hours. And then this was correlated with their bilirubin levels on day 6. And they found that the number of times a mother breastfed in the first 24 hours directly correlated with the risk of having a total serum bilirubin level of greater than 15 milligrams per deciliter on day 6. Here's a larger view so you can see how directly correlated the number of breastfeeds in the first 24 hours is to the rate of bilirubin. And I think part of this is the mechanism would be that that all of the stimulation of repeated small feeds gets mother's milk supply in faster, her full milk supply, and then also these small frequent snacks would lead to maybe more passage of meconium for the baby, and both of those mechanisms would help us decrease the risk of hyperbilirubinemia. We need to remember that the numbers we graph on the Butani nomograph reflect risk factors, not diagnostic levels. At 24 hours, a level of 5 milligrams per deciliter predicts that there is a low risk of subsequent bilirubin levels being above the 95th percentile. And a number of 7 milligrams per deciliter predicts that there's a higher risk of the subsequent bilirubin levels being above the 95th percentile. Now, if the number is between the 75th and the 95th in the high intermediate risk zone, this does not mean that we need to start phototherapy. It just means that we need to monitor a little more frequently so that we can determine the rate of rise. If the rate of rise is greater than 0.2 milligrams per deciliter, then the next bilirubin is likely, or the subsequent bilirubin levels are likely to cross the line over into the 95th percentile, and it would be appropriate to start phototherapy. And of course, babies do need to be monitored more closely when they're in those levels and if they have any risk factors. Now, if phototherapy is indicated, it is recommended that it be done in mother's room if possible and that exclusive breastfeeding be continued. Even if there are banked lights, the babies can come out of banked phototherapy to breastfeed for up to 30 minutes at a time, and that doesn't seem to reduce the effectiveness of the treatment. Of course, we're not talking here about babies who are approaching exchange transfusion levels, but just our normal bilirubin phototherapy levels. Home phototherapy is encouraged if possible, but not if babies have risk factors such as hemolytic factors. And babies that are breastfeeding and readmitted from home should be admitted to a unit where mother can stay and breastfeed can continue without interruptions. Babies receiving phototherapy with a fiber optic blanket are usually happier babies than ones on a billy bed because they can continue to be held by mother or father. About a few years ago, an article in Pediatrics described a novel and very successful method of providing phototherapy with overhead lights in a way that did not interrupt breastfeeding or separate mother and baby. Babies could even do skin-to-skin during this type of therapy. Mothers were supplied with amber-colored glasses that protected her eyes from overhead therapy. And of course, the baby wears the billy masks. Now, if starvation jaundice is not the issue, supplementation is usually not necessary if mother is available and willing to breastfeed frequently. Yes, it may bring the bilirubin level down a slight bit faster, but if there's no hemolysis going on or other serious risk factors, is a few more hours on phototherapy really worth the known risks of introducing formula and sabotaging exclusive breastfeeding? All too often, supplementation is the first response to hyperbilirubinemia or any hint of any other problem. The guidelines recommend supplementation only when there is clear indication of inadequate intake, such as a weight loss greater than 10% after attempts to correct breastfeeding problems, or a documented failure in milk production or transfer, or clear evidence of dehydration, such as abnormal electrolytes, etc. If it is determined that supplementation with artificial milk is needed, there is evidence that hydrolyzed protein formula may be more effective in reducing bilirubin levels. And we want to avoid excessive amounts of formula to preserve mother's milk supply at high levels, and also because there's small gastric volume in the first few days. Of course, we still want to ensure adequate intake and volumes. And the recommendations are to avoid the use of nipple teats and bottles if possible. Supplemental nursing system devices or cups are suggested, and I have found that many mothers are very open to using supplemental nursing systems so the baby stays at the breast. Others are just not able to do that, so I think we need to offer it and then accommodate mothers' wishes. Full-term babies need very little volume in the first few days after after birth, and this is really an important thing to remember. This guideline recommends just up to 5 milliliters per feed in the first 24 hours, and then 15 in the second 24 hours, and 30 in the third day, and then so forth. We know that the capacity of the newborn stomach after birth is very small in the first 2 days. In a 3-kilogram baby, the average physiologic capacity of the stomach is about 6 milliliters on the first day and about 12 milliliters on the second day. Now, if you multiply that by the number of feeds they're likely to have on those days, you get the amount of milk that almost exactly matches the volume of mother's colostrum. This study found that during the first 24 hours after birth, newborns ingested only about 15 plus or minus 11 grams of milk, not per feed, but actually for the whole day. This study found that stomach volumes were 7.5 milliliters on the first day, and you can see what they are on day 2 and 3. And I find there's just so many decimals and fractions here, it's very hard to remember. So for my own practice, and what I recommend is that we just consider up to 10 milliliters per day on the first day, up to 15 or 20 on the second day, and up to 30 on the third day. And that's very easy to remember, 10, 20, 30, or 10, 15, 30. Having a visual aid that shows babies about the size of mother's stomach is very baby's stomach is very reassuring to mothers. Many mothers have a misconception that they need to feed a baby this large volume of milk from the very first few feedings. And if they know that the baby's stomach is quite small and quite tight in the first 2 days and doesn't expand readily, then it's very reassuring for them to know that they can make enough milk for their babies in those first 2 days. And that all that stimulation of the small frequent feeds will cause her milk supply to increase by the second or third day, and then her baby's stomach will be able to stretch and receive it. Unless there's a reason a newborn is losing fluid, such as fever or rapid breathing, etc., or transcutaneous or wound losses, a newborn does not need actually 80 milliliters per kilo of fluids, either orally or IV. I think we are seriously overhydrating asymptomatic babies who are not dehydrated, especially when they're admitted to the NICU to rule out sepsis, etc. The Academy of Breastfeeding Medicine cautions that although IV fluids may be indicated if the baby's dehydrated, that they should be discouraged because in asymptomatic babies because they may inhibit thirst and diminish oral intake. The AAP guidelines also are very similar, and they promote and support breastfeeding as a way to decrease the risk of hyperbilirubinemia. They advise mothers to nurse their infants at least 8 to 12 times per day for the first several days, and document that poor caloric intake may contribute to the development of hyperbilirubinemia, and that we need to increase the frequency of nursing in order to help prevent that subsequent hyperbilirubinemia in breastfed infants. And the most important thing is to provide adequate support, and this increases the likelihood that breastfeeding will be successful. They argue also against routine supplementation of non-dehydrated breastfed infants with water or dextrose water, orally or IV, and remind us that it does not prevent hyperbilirubinemia or decreased total serum bilirubin levels. It's important to support mothers by reassuring her that hyperbilirubinemia is not her fault, there's nothing wrong with her milk, breastfeeding is still optimal. Explain the temporary nature of intervention and that jaundice is not likely to reoccur, and assure an adequate lactation support and adequate family support. Early weight loss is another reason many babies get supplemented with formula, and many of them unnecessarily. We know that 7 to 10% weight loss is considered normal for breastfed babies, and they're usually back to their birth weight by 10 to 14 days after birth. We must remember that 10% of birth weight loss is not equivalent to 10% dehydration. It's simply a diuresis, a normal expected diuresis. And it does warrant attention and evaluation, especially if it's a late preterm infant, and we need to make sure that they are adequately supported. The experts say that we can expect an average of 7% weight loss in the first week, and that if that occurs early, that breastfeeding should be observed by a trained professional, and if the baby is nursing well and is otherwise healthy and has good output, then we can safely do another weight check in a couple of days. We know that we've suspected for some time that that IV fluids used in labor contributes to increased urine output in the first couple of days and increased weight loss for babies. And there's been 2 studies recently that have documented that that was true. Actually, that was in 2011 now. It's been out for 5 years. So in this study, this is actually the study. In this one here, it says both of these studies document that infants' initial weight loss may be greater than 10% simply due to surplus fluid loss. And this is the first study that was done by Dr. Chantry, and you can see how the more fluids the mother got, the higher the adjusted risk ratio of having excessive weight loss for newborns. Her conclusion was that interpartum fluid administration can cause fetal volume expansion, the babies just simply weigh more, and then greater fluid loss after birth. A second study done the same year looked at all the mother's maternal oral and IV fluids during labor and before C-section, and then you can see the methodology here. They weighed the babies and weighed the baby's output. They found that the more fluid that mothers got, the more the babies lost weight. And correlated to their urine output and their weight loss. So their conclusion was that the timing and the amount of maternal IV fluids was correlated with neonatal output and newborn weight loss, and that newborns appeared to experience diuresis and correct their fluid balance in the first 24 hours, and they actually recommended that, that we measure the babies at 24 hours, that we use that weight as a baseline for assessing weight change rather than the one at birth, which could be inflated with maternal IV fluids. Now, lactation support focus has primarily focused on 3 critical determinants. First, we want to get a good milk supply. Then we want to get the milk supply in the baby. But the third thing that we have to always remember is to support maternal confidence. As I mentioned in the beginning, I often find that there's a lack of confidence in mothers that they can successfully breastfeed. And these are the 3 most common issues that account for the largest drop-off in breastfeeding, which occurs in the first few weeks postpartum, and it accounts for the fact that we are not meeting our 2020 goals. So here's some common concerns that I have found, especially in the newborn nursery where I work with normal newborns, that I hear day after day after day coming from mothers. I don't have enough milk, or I'm afraid I won't have enough milk. My baby doesn't know how to breastfeed. My baby doesn't want to breastfeed. I'm too tired to breastfeed. I'm going back to work, so I want my baby to get used to the bottle. I want dad to feed the baby so that they will bond. I'm afraid my baby will just use me for a pacifier. I don't want to spoil my baby. My baby is crying, so he must be hungry. Have you heard any of these? I'm sure you have, because this is what we hear from day to day. So I got an idea from the Stanford website, which I would highly recommend, where I read a script that they suggested for one of the challenges postpartum nurses often face when addressing mothers' concerns about breastfeeding. So I decided to create some of my own from things that I have found useful when talking to mothers about these concerns, when this is a period of time when they have a lot of doubts about whether or not they will be successful in breastfeeding their babies. So I've supplied them here, and a handout will be available to you if you're interested in having these. And I would just encourage you to just play around with them, make them your own. There's many right ways to say these, and I've identified the key concepts. If a mother says, I don't have enough milk, I'm really worried that I don't have enough milk for my baby, this is the time when we can say you have the perfect volume of milk for your baby's stomach today. Your baby's stomach volume is very small, but it perfectly matches the amount of milk you have right now. Babies need small volumes to suck, swallow, and breathe without choking in the very beginning, and they can also practice while your breasts are soft. When your milk volume increases in a few days, your baby will be really good at feeding and ready for larger volumes. We've been advised to avoid the phrase, when your milk comes in, because that implies there's nothing there now. So mothers, you can increase your milk volume faster by holding your baby skin to skin and feeding your baby frequently every 1 to 3 hours. And then, of course, if you want to increase it even faster, you can hand express milk. And then we need to teach mothers how to hand express milk, and we can show her pictures. And I love what the lactation consultant does at our hospital in Murrieta when she shows a mother that when she hand expressed milk and she sees a few drops of colostrum, she just so enthusiastically says, oh, look, you have tons of colostrum. And it's very, very encouraging to mothers. When a mother says, my baby doesn't know how to breastfeed, I know that baby probably didn't get the sacred hour, and we can remind her that all newborns are born knowing how to breastfeed. Breastfeeding is one of their natural instincts, but they need to be skin to skin with mother for their natural instincts to be activated, at least in the very early period after birth. Having clothes on and being wrapped in a blanket can be confusing to many babies. And within a few days, they will be very good at breastfeeding with clothes on. But in the first day or so, they need to have as much skin next to mother as possible so that they can activate those instincts. So this is what I often see, is a bra with a breastfeeding bra, a nursing bra with just a little bit of skin showing, and baby wrapped up in a blanket, often those silly little slits in the hospital postpartum gowns, and baby has no skin-to-skin contact, or very little. What we want is to unsnap those gowns, take the clothes off the baby, have just a diaper, and have mom bare from the waist down, and then all that whole abdomen skin to skin with mom, and that will activate those feeding instincts. If a mom says my baby doesn't want to breastfeed, this must be a sleepy baby. And we want to remind mom that many babies do sleep a lot on the first day, particularly if they have had a lot of IV medications, if mom has had a lot during labor. We can remind moms that babies are just recovering from birth too, and that baby's just trying to figure out the world, that the baby steps of learning will come more naturally if we keep your baby skin to skin and just practice breastfeeding. In the meantime, though, we need to phone in your order for lots of milk because the baby will need it after about 2 to 3 days. So if the baby's not feeding well, we need to pump or hand express the milk and feed it to the baby in several different ways. And remember, this is a learning time for you, so put your light on if the baby starts, for both of you, so put your light on if the baby starts moving around or wakes up, and I'll come in and help you. And of course, for any baby that's not feeding well, we want to closely observe them for any signs of sepsis. And moms, all moms need encouragement. You're doing a great job. So if a mom says, I'm too tired to breastfeed, we just need to give sympathy. I know it's hard to get used to feeding the baby as often as he or she needs to eat, but it will get easier. And it may seem easier to bottle feed now, but it's really much easier to breastfeed once you get the hang of it. Is there anyone who can help you with other things so that you can sleep whenever your baby sleeps? Maybe it's a good idea to limit or eliminate all extra visitors for now so that you can concentrate on feeding baby and sleeping. Very often we know a multitude of visitors really interferes with early breastfeeding and also any sleep that the mother can get. Many moms are worried about going back to work, and they know that their baby needs to get used to the bottle because they will eventually need it. So we can remind moms that feeding from the breast and from the bottle require completely different mouth and sucking movements. And babies can be confused by trying to learn both at the very same time, especially in the beginning. Or babies may learn to prefer the bottle because it's easier just to swallow than to suck milk out. Babies who learn to bottle feed first often don't breastfeed well, but babies who learn to breastfeed first usually can go back and forth later on. So the key is it will be worth it to focus just on breastfeeding during the first few weeks after birth, and then you can introduce a bottle later, about 3 weeks or so before you go back to work. Many dads want to feed the baby because they think that's the only way that they can bond. So we need to remind them that dads and babies can bond during diaper changes or baths or skin to skin. That's a really important time when dads can bond with babies. It is really important for dads and babies to form strong bonds, but there are many bonding opportunities other than feeding. I'm afraid my baby will just use me for a pacifier. We hear that a lot from moms. The thing I wonder is why aren't we concerned that babies will just use pacifiers as substitute for mothers? That's really what's going on. So we can remind mothers that babies need almost constant closeness with their mothers and very frequent suckling, and that it's normal for babies to want to breastfeed frequently, to get small, frequent snacks, and also normal for babies to want to be close to their mothers for most of the time. So if you meet your baby's needs now, he will need you less as he gets older. I heard a saying once that said, if you treat a baby like a baby when he's a baby, then perhaps you won't have to treat him like a baby for the rest of his life. Many parents are worried about spoiling their baby, and it's important to remind, especially new parents, that it's not possible to spoil a new baby. Babies learn trust in the first year of life only if their needs are promptly and consistently met. And independence is their task during the second year. Babies should not learn independence before trust. In fact, it's impossible for them to do it. Crying is one way a baby communicates a need, and studies have shown that if a crying baby is picked up within 90 seconds, the crying usually stops, and those babies cry less at a year if their needs have been consistently met. So don't be afraid to meet your baby's needs for touch and closeness. And I love Peggy O'Mara's quote, "Don't stand unmoving outside the door of a crying baby whose only desire is to touch you. Go to your baby 1,000,000 times." My baby is crying, so he must be hungry. We need to remind parents that crying can mean many things. It can mean hunger or discomfort or pain or overstimulation or boredom, just wanting something different, or simply loneliness. Sometimes it takes a bit of detective work to figure out what your baby's trying to tell you. So let's see if we can figure out what is bothering him. It's important for parents to understand infant crying, and Jane Heinig from UC Davis has a wonderful seminar about understanding infant crying and behavioral cues. and has developed some wonderful material for the WIC program to help parents understand babies' behaviors and how to interpret infant crying. She reminds us that crying is a basic instinctive communication designed to elicit an adult response. It's a vital infant superpower that's critical for survival. And mother's concern is a basic instinctive response designed to meet the needs of a distressed infant, and she should not try to suppress it. This brings us to breastfeeding myths. There's several great expectations that uninformed new parents have, and that is that mother's milk will come in on the first day after birth, baby will latch perfectly every time, baby will cry briefly, feed easily, then be quiet and go to sleep, eat 3 to 4 times a day, and parenting will all be easy. This is the imagined baby that anybody can breastfeed, and this is the real baby that mothers are not quite so sure. This baby represents some challenges, and every mother has moments of doubt. Can I really breastfeed my baby? There's a triad for breastfeeding failure that's well recognized. First is unrealistic expectations about newborns and about breastfeeding, a lack of preparation for breastfeeding, and formula seen as the solution to all problems. The reason this happens is that people say, I gave him a bottle and he stopped crying. Well, the truth is no one can cry and swallow at the same time. So if forced to swallow, crying will stop, even if hunger was not the reason for the crying, which of course is a setup for feeding to solve all adult problems. So we need to warn parents on day 1 about day 2. Because on day 1 there is brief crying, and baby breastfeeds during quiet alert states and sleeps for long periods. But on day 2, baby is awake and crying and everyone thinks something's wrong. We need to do something. So parents need to understand infant sleep cues and sleep states. Infant cues are often subtle and simplistic and not specific, but we can teach them about engagement cues, disengagement cues, and hunger cues. Because if we miss them, we're going to get the expected results. Here's some great resources, and there are others that can help teach. They're designed specifically to help teach new parents about infant cues. Understanding infant sleep is really useful. Babies don't sleep exactly like adults. They do have sleep cycles of about 60 minutes, and about half of that is active sleep, where the baby has a little tone, there's rapid eye movement, and this lasts about 20 or 30 minutes. Then there's another 20 or 30 minutes of deep sleep, where the baby has no tone, no rapid eye movement, or very little tone, and no rapid eye movement. And what we need to tell parents is when they can watch for these different parts of the sleep cycle, and when they see baby in an active sleep, this is a good time to invite them to feed if it's been longer than 3 hours since their last feed. If they're in the deep sleep cycle, this is not a good time to invite babies to feed. In fact, it's a waste of time to try to wake them up. But we can just watch for the active sleep cycle to come around and then try to wake baby up during that time and invite them to feed. We can use baby as a teaching tool whenever we see the sleep cycles, or when we see that baby's trying to want something different, and baby themselves can help us to teach parents about feeding cues and other cues. The last thing we need to do is warn parents about growth spurts. These are periods of frequent feedings that mothers often perceive as an insufficient milk supply, and it's a major reason that mothers stop breastfeeding. So we need to provide an explanation that has 3 parts. Number 1, it is normal. This is nature's way to increase the milk supply for a growing baby. And in order to reassure yourself that your baby's not starving, count the wet diapers for reassurance. It should be at least 6 by then per 24 hours. It's predictable. The first episode often occurs in the 2nd or 3rd week, which is why babies should be having at least 6 wet diapers in 24 hours during that time. And it reoccurs every 4 to 6 weeks. And third, it's temporary. These frequent feedings are only going to last 2 to 3 days. So when babies are in the colostral phase, they often feed every 1 to 2 hours, and then when the milk supply increases, they're feeding every 2 to 3, and when they go into a little growth spurt like this, they go back to every 1 to 2, but only for 2 or 3 days. And if we count the wet diapers, we'll be reassured that the baby is not starving. The last issue I want to bring up just briefly is breastfeeding in public. We know, because this is a concern for many parents, we know that we have a serious double standard in this country. This public official was saying, nursing, this is a shopping mall. We can't allow women to brazenly display their breasts. There are still people who have never seen a baby breastfeed, and there are still many, both men and women, who think that the primary function of the breast is for sexual pleasure. And every aspect of media in our country supports this, from advertising, TV, and movies. Apparently this problem is spreading to the animal world, to those who dare to udder feed in public, but the media knows what to do when other mammals brazenly feed their babies in public. Now, babies don't seem to know what all the fuss is about. They have no problem nursing in public, wherever they happen to find a seemingly available milk source. But if our children see breastfeeding as the normal way we feed babies, then it will become the normal way to feed babies for our daughters, and even become the normal way to feed babies for our sons. I'm quite certain he will figure out in time that boys don't breastfeed, but chances are good he will be supportive of his wife breastfeeding their babies. And soon there will be less of these in department stores to signify a mother's room, and in shopping malls we'll see more of these, which support breastfeeding. We know that mothers need to go outside the home for shopping and taking children to school and going to church and out to eat, to the park, etc. And babies need to eat while their mothers are away from home. We will not be a culture that truly supports breastfeeding until breastfeeding in public becomes the norm and is no longer considered unusual or strange. It's simply the way babies are fed. These beautiful little business cards are available in Texas to give to mothers seeing breastfeeding in public, and they say, "Thank you for nursing your baby in public. May future mothers never have to search for a secluded corner or dressing room or a restroom to nourish their babies. Nursing in America is becoming the norm, and the credit goes to women like you." So we know that all babies are born to breastfeed, and we know that although initiation rates are the highest they've ever been in recent history, exclusive breastfeeding rates in our country are still far from ideal. We are not yet a breastfeeding culture when it comes to exclusive breastfeeding in the first 6 months. And as we said in the beginning, if we want mothers to exclusively breastfeed for the first 6 months, first we need to help them exclusively breastfeed for the first 6 days. Even mothers who want to breastfeed their babies require considerable support in the early postpartum period to achieve their own breastfeeding goals. But it is worth the effort for babies, for mothers, for families, and for our society. So thank you for all you are doing to empower mothers to meet their breastfeeding goals and encouraging them to exclusively breastfeed their babies for the first 6 months after birth whenever possible, and to continue breastfeeding for as long as mother and baby both want to continue physically and emotionally nourishing each other. Thank you so much. All right, I'm happy to take any questions if there are any. Well, when I click on questions, I see nothing. Oh, there's one comment that says, please make slides available, and I'm very happy to do that. I will send a link to the PDF of these slides so that you can have them available.
The entire presentation to the Maryland policy website.
Right, the recording will be available through that website, but I will also be happy to make the slides available as well.
Thank you.
Thank you. One person commented that this information would be should be made available to nurses doing the on-the-spot education and support, and I couldn't agree more. There are several good prenatal breastfeeding programs. I know that we developed one in our county that was designed to be used in the waiting while mothers waited for their prenatal appointments. There's several little videos that are available. So I think that probably there's many good breastfeeding prenatal programs. The important thing is that they need to be accessible to parents who are pregnant mothers. And I was told recently that only about 10% of the mothers giving birth at our hospital attended any kind of a prenatal breastfeeding or birthing class. So we probably need to find more innovative ways of reaching out to mothers, probably within the prenatal clinic visit itself. There needs to be some material, and that was what this program was designed to do. So I think we have room to improve the dissemination of breastfeeding information in the prenatal period. And that's what this individual is saying, periodic screening in pregnancy and postpartum, like our prenatal visits and periodic and pediatric schedules. Yeah, it absolutely needs to be brought up at every visit. Every OB prenatal visit, breastfeeding should be brought up and information should be shared. I think that's the ideal way, actually, of sharing prenatal breastfeeding information is in the prenatal visit. And then also postpartum, the pediatric, there needs to be actually outpatient clinics, because by the time babies get to their postpartum or the baby's first checkup, the big issues are often, big challenges are being met during that first 2-week period. And so outpatient breastfeeding support is absolutely essential in the first 2 weeks, not waiting until the 2nd, 3rd, or 4th week for mothers to get the help that they need. So I think an outpatient breastfeeding clinic should be a part of every single hospital's services to mothers.
All right, then. We'd like to thank all of those who joined us for this presentation, and we'll hope that you'll be able to view our other presentations in this webinar series. Dr. Phillips, thank you so much for your presentation.
You're welcome.